I was really curious about the population specifically. There's two subgroups in the analysis, the modified intention to treat or MITT and safety populations. Can you help us understand the differences between these two populations, and are there any differences you see?
Absolutely. So we looked at two cohorts for this analysis. The modified attention to treat cohort was the group of patients that were used for the primary analysis for the trial. And so that was separated into patients with acoramidis treatment and placebo. And among this group, we had adjudicated cardiovascular hospitalizations, and not only cardiovascular hospitalizations, but the cause of cardiovascular hospitalization, whether it's heart failure or atrial arrhythmia, et cetera. And so now in this analysis, we look specifically at the rate of cardiovascular hospitalization due to atrial arrhythmias, atrial fibrillation, or flutter. The safety cohort is a little bit different. It's a little bit larger because it includes a small number of patients that weren't in that modified intention to treat analysis. But this is safety reporting by the individual sites. So if there is a reporting of atrial fibrillation or atrial flutter, that would include patients that perhaps developed this during the trial or had issues with it that were seen in an outpatient setting or managed, not necessarily in the hospital. And so I think there are kind of two different ways of looking at the burden and incidence of atrial arrhythmias in these patients. And what we saw was in the analysis, and I guess we can delve into the results a little bit more soon, was that number one, the study populations were very similar between the safety cohort and the modified intention to treat, and the trends that we saw were similar in both groups as well.
Yeah, it's a great segue into our next question. So let's talk about the main findings. So how did acoramidis perform in terms of reducing AFib and aflutter-related events, including treatment-emergent adverse events, as well as those cardiovascular hospitalizations?
Of course, yeah. So in the modified intention to treat cohort, where we looked at hospitalizations due to atrial fibrillation, we saw that there was about a 43% relative risk reduction in the rate of cardiovascular hospitalizations due to AFib in the acoramidis treated group. So the rate was about 3.7% in the acoramidis group and 5.4% in placebo. When we looked at the safety cohort and reported adverse events, we saw a similar trend in terms of a lower incidence of atrial fibrillation, atrial flutter events in the acoramidis group compared to placebo. And this was about 17% lower incidence rate in acoramidis. And when we looked at the safety cohort and split it between patients who had had prior atrial fibrillation before the trial, or prior history of atrial fibrillation before the trial versus patients who had no prior history of atrial fibrillation, we saw a similar 17% lower incidence of atrial arrhythmias in that acoramidis treated group.
Those are really impressive results. And I'm wondering what the clinical significance could be here. Could this influence how we monitor or manage ATTR cardiac amyloidosis?
So I think these were interesting results to see how disease modifying therapy, in this case, a transthyretin stabilizer, could affect the pathophysiology of ATTR amyloidosis. And we know that the progressive amyloid buildup causes a variety of problems: diastolic dysfunction, heart failure, arrhythmias, and conduction disease. And so now we have one more piece of information to show that the disease modifying treatment with acoramidis can affect downstream sequelae such as atrial arrhythmia. And so that's another piece in addition to what we've seen for heart failure. And so I think, to be clear, I don't think there's a direct mechanistic link that TTR stabilization decreases arrhythmias, that it at the biologic level decreases kind of that rhythmic substrate. I think it's more reflective of the fact that we're slowing or preventing disease progression, thereby not seeing as much of these downstream sequelae such as atrial arrhythmias. And so I think that has important implications to kind of our understanding of the disease and the potential impact of therapy and the overall, managing the overall burden of disease of these patients.